Hello, Andrew Kolsky from Stop My OCD, and today we're going to talk about a journal article regarding exposure and response prevention for OCD. This is a review and new directions. It's an article by Hessel and Simpson from the Indian Journal of Psychiatry, January 6, 2019. Let's see what they have to say. But first, I'm Andrew Kolsky. I am an OCD and anxiety treatment specialist, and you can find out more about me and my practice at www.stopmyocd.com. So considered one of the most debilitating psychiatric illnesses, OCD, or obsessive compulsive disorder, is characterized by distressing thoughts and repetitive behaviors that are interfering, time-consuming, and difficult to control. The currently scientifically validated and successful treatment methodology for OCD is exposure and response prevention therapy. It's also called ERP, or exposure and ritual prevention therapy. Let's take a look at the history. The first significant non-pharmacological advance in treatment occurred after a scientist by the name of Meyer reported that patients' OCD symptoms improved when they were exposed to feared stimuli while, crucially, refraining from performing compulsions. So prior to ERP, we simply had medications that the doctors and scientists tried to use to address obsessive compulsive disorder to certain benefit, but really not as far as we have come today now that ERP has become the gold standard. Another scientist by the name of Maurer created a two-factor theory of fear and avoidance, which provided an influential framework for understanding the etiology of OCD that inspired the development of behavioral treatments for the disorder, including ERP. Maurer asserted that individuals experience anticipatory anxiety in the presence of environmental stimuli that are associated with painful or aversive experiences through classical conditioning. Subsequent avoidance of the feared stimuli serves to alleviate people's anxiety, which in turn reinforces the avoidant behavior through operant conditioning. So oftentimes you'll hear people talk about, why does someone have OCD? And they'll say part of it is biological and part of it appears to be behavioral, because the behaviors that we develop in response to the biological urges we have related to OCD tend to strengthen themselves by building upon themselves. In other words, we have a certain behavior, we get a response that we like from it, so we do more of that behavior. The problem is that goes a little bit awry with OCD, and that's why we need to kind of recalibrate things. So early studies demonstrated ERP superiority in reducing patients' OCD symptoms relative to other things that were tried, such as relaxation therapy, anxiety management, or a waitlist condition. So people who have generalized anxiety may be taught how to address their anxiety through relaxation, through anxiety management, through different types of coping skills. And oftentimes that can be effective for them. However, when you get into OCD or some severe types of generalized anxiety, the person doesn't really benefit from that approach. They benefit from being exposed to the stimulus that causes them to have the reaction, and then we prevent them from doing the compulsions that they normally do so that they learn how to deal with the experiences through OCD, which we're going to talk about in a minute here. So 2/3 of patients who received ERP experienced improvement in symptoms, and approximately 1/3 of patients were considered to be recovered. The majority of patients treated with cognitive behavioral therapy without ERP, or cognitive therapy minus the behavioral part, also experienced a reduction in symptoms post-treatment, but ERP outperformed the other treatments. So ERP is a form of cognitive behavioral therapy, but it's a specialized form, and it outperforms cognitive behavioral therapy or simple cognitive therapy. Specifically, there was a slightly stronger effect size for ERP, and it resulted in lower OCD severity scores post-treatment relative to the other two modalities. So this is part of the study that shows and proves that ERP is the most effective approach to treat OCD. Additional review provides further support for the treatment's utility in a variety of settings, in the person's home, in their office, or delivered in different intensities, such as weekly or intensive treatment, and with pediatric and adolescent populations. ERP has also been shown to lead not only to symptom reduction, but also to a decrease in sleep disturbances and improved quality of life more generally. So, for example, with my patients, most of the time I choose to do telehealth. And the reason for that is because many of them have OCD-related obsessive thoughts or obsessive doubt that is focused on something in their home or their workplace. And if they come to my office, they're not in the right environment to be able to be exposed to the stimulus that causes the OCD. So by doing telehealth, they can actually be at home on the computer. If they've got something related to touching the faucet in the bathroom, they can simply bring the computer in with them and we can have them touch the faucet and do therapy that way. Or maybe it's something in their kitchen or their living room. So it's much more effective, in my opinion, and in my practice, to do therapy where the issue occurs. Now, medication is also something that is relevant for OCD treatment. The study found that individuals taking a combination of medication and also doing ERP had similar outcomes to individuals in ERP alone, but improved more than individuals on medication alone. So this showed that ERP improved more than just taking medication. At the end of 12 weeks, participants treated with ERP or a combination of ERP plus medication showed a greater decrease in symptoms relative to those treated with clomipramine alone. Clomipramine was the medication they were testing in this particular study. Medication did not bolster the efficacy of ERP. So basically, what does that say? It says that if we use ERP, that's the most effective approach. If we use ERP with medication, we might even get a better outcome, but medication alone does not solve the issue, and medication does not bolster ERP. ERP alone works well, but it works even better when we supplement it with medication. In my personal experience, there are a good number of patients who do fine with ERP alone and don't need any medication at all. There's also a number of patients who definitely benefit from medication, but medication is not going to solve the problem. Medication helps, but ERP is the thing that really works us towards a resolution of the problem. Patients on a stable dose of SRIs experienced greater symptom reduction after additional treatment with 17 weeks of ERP compared to those who received augmentation with stress management training. And individuals taking SRIs had lower OCD severity scores immediately and 6 months following additional treatment with ERP than those who had additional treatment with risperidone or placebo. Guidelines recommend ERP as the first-line treatment for OCD. Only about half of the patients who receive it will reach complete symptom remission. So, we talk about complete symptom remission versus significant improvement. Those are two different things. Some people will reach complete symptom remission. A lot of other people make significant improvement to the point that OCD really doesn't have much of a harmful effect on them. It is something that can come back and rear its head again in the future, but proper treatment teaches you inhibitory learning, which is a way to be skilled and prepared to address OCD should it come back. So how it works. Cognitively, ERP works by disconfirming people's distorted beliefs through exposures. A behavioral perspective asserts that ERP works by breaking the conditioned response between obsessions and compulsions. Accordingly, compulsions temporarily alleviate people's anxiety that obsessive thoughts trigger. The decrease in distress strengthens the rituals and conditions people to continue using them when confronted with subsequent intrusive thoughts. On the other hand, when individuals confront triggering situations while simultaneously refraining from engaging in rituals, their distress decreases naturally in the absence of their feared outcome. With repeated exposure, the fear response is eventually extinguished and OCD symptoms subside. So what does that all say? It basically says that if we expose you to the stimulus that causes the obsessive doubt, normally, without treatment, you turn to a compulsion, which is something that you do that helps you reduce your distress, but it only tends to work temporarily. So, common example, someone who has contamination OCD, they fear that their hands are dirty and they're going to spread contamination around. Their compulsion is to go and wash their hands. They wash their hands, that reduces their distress. They don't feel that their hands are contaminated anymore for a certain amount of time until the obsessive thought comes back and they need to do the compulsion again and wash their hands again, typically even more rigorous this time. So with ERP, we will expose them to actually making their hands dirty and then not doing the compulsion. And initially, their distress will rise because they're not doing their compulsion. So they're really feeling that distress. But given time, the distress starts to come down. And they start to learn that the beliefs that I had about these horrible things happening didn't actually come true. And they're not really, there. So I'm able to realize now through new learning that these things are safer than I thought they were. So this theory states that exposure therapy provides information that is contradictory to the existing fear structure when patients' dreaded outcomes do not occur. Consequently, individuals form new, more realistic memory structures that do not include a pathological fear response. Repeated practice confronting distressing situations strengthens the activation of this competing structure, thereby weakening the occurrence of the fear response. More recently, researchers have proposed that inhibitory learning is central to extinction through exposure therapy. Specifically, this theory purports that the initial conditioned association between the stimulus and the unconditioned fear response does not disappear, but rather that a new association is learned that competes with the former response. I have some other videos out about inhibitory learning, but again, basically, we learn that the horrible things that OCD tries to tell us could or would or are going to happen don't actually happen. And we're able to then deal with the distress because we don't have the outcomes that we thought we would have. So therefore, the newly formed association inhibits the memory of the original excitatory response with repeated practice, but does not prevent it from being reactivated at some point in the future, thus underscoring the importance of continued exposure to once feared stimuli. Again, the more exposure we do, the more you learn, the more inhibitory learning you achieve, the stronger you are, and the better prepared you are to deal with OCD should it come up again. So, for example, using a neurobiological framework, scientists propose that compulsions are the result of excessive habit formation and that obsessions develop when the sufferer makes inferences about his or her behavior. I checked the knobs on the stove, so I must be afraid of accidentally starting a fire. Therefore, when refraining from engaging in compulsions during ERP, the patients are learning to break the habitual ritualistic behavior, which in turn reduces obsessions. So one of the biggest issues that we have out there is access to care related to OCD treatment, exposure response prevention, medication, etc. There are numerous barriers to treatment, including high costs of care, stigma surrounding mental health issues, and lack of access to clinicians who are trained in evidence-based practices. It's a very small number or a small percentage of people who are trained to work as mental health professionals who actually have training in OCD. So one solution to improve access to care is the development of an internet-based ERP program that individuals can use to guide themselves through treatment with the support of a therapist through email, phone, or the online treatment platform. Again, this is one of the reasons why I offer telehealth. I can work with clients who are not within, a certain radius of a physical office, so they can't get there even if I did want them to come into the office, which, as I described earlier, I really don't. Also, we have internet technology, one of them, which is new and really effective for this, just being launched, is rxxrt.com. It's where exposure therapists can provide exposure therapy to you over the internet. Results from studies implementing these internet programs are promising. They have demonstrated not only the feasibility, but also the efficacy of delivering ERP online. Specifically, individuals who completed these online programs experienced a clinically significant decrease in OCD symptoms, which were maintained at follow-up. Given the growing ubiquity of internet access and cellular phones, continuing to develop programs that increase the dissemination of ERP is worthwhile. So these scientists are very much on board with using the internet and technology to help us better provide OCD treatment. They also looked at another treatment modality, called attention bias modification. In a study, half of the patients were trained to shift their attention away from threatening words, i.e. related to contamination, and the other half did not receive such training. Relative to those without training, individuals in the trained attention bias modification group were less avoidant of contaminated objects during a subsequent behavioral approach task. It is possible then that reducing attention to threat may diminish avoidance behaviors, thus making people more willing to engage in exposures. However, a subsequent study using a clinical population found that ABM alone did not reduce OCD symptoms, thus suggesting that it may be more effective in addition to ERP rather than in place of it. So there's an option to add on some additional modalities to ERP, but ERP continues to prove itself to be the gold standard. Virtual reality. We just talked about technology, up and coming opportunities with the internet and other technologies. Well, virtual reality is being studied as a way to enhance exposure therapy for a number of disorders, including post-traumatic stress disorder and anxiety disorders. Although it has not been tested extensively with OCD patients, a preliminary study demonstrated its effectiveness in triggering and measuring anxiety in people through a virtual reality platform. Virtual reality may be especially effective in designing exposures to situations or stimuli that are impossible to reproduce in vivo in real life and are otherwise left to imaginal exposures. So maybe you have OCD related to something about being on a ski lift. Well, there's only certain times of the year and certain places in the country that you can go to physically actually be on a ski lift. And if we're trying to treat you in the summertime in Florida, it's going to be pretty hard to do that. But with virtual reality and similar technology, we can easily do that. Medication. Some studies have investigated the advantage of enhancing ERP with medication implicated in facilitated extinction learning. Specifically, research demonstrated that relative to those given a placebo pill, patients taking D-cycloserine before engaging in exposure therapy experienced a faster rate of symptom improvement in the first few weeks of receiving ERP. However, there were no group differences in symptom improvement by the end of treatment, suggesting that the drug's utility lies primarily in speeding up treatment response. So again, there's a lot of different medications that are being tested out there that have promising results in one way or another. Here's another one that may help speed up ERP. But again, everyone is different. And in my experience, we typically have a lot of success with ERP alone. And those people who will benefit from medication it becomes apparent as we begin treatment. Other treatments besides ERP, besides medication, there are several surgical and non-invasive neurological interventions that are available to patients who have not had success with psychotherapy or medication. Neuromodulating methods such as transcranial direct current stimulation and transcranial magnetic stimulation, as well as surgical procedures such as deep brain stimulation, work to decrease symptoms by targeting underlying neurocircuitry implicated in the pathophysiology of OCD. So basically, you've got ERP as your primary, you've got medication to bolster your ERP. From there, there's some other treatments that can be add-ons or assistance, but still ERP remains the gold standard. And for someone who has treatment-resistant OCD, you can move into things such as the transcranial magnetic stimulation, transcranial direct current stimulation, and in the most severe cases, there are surgical procedures that are available that have proven to be successful and effective. So with all of that, it's important that we get the message out to help break the stigma surrounding OCD. I do these videos because I'm trying to educate the public and help people understand what's really going on with OCD, what's the current science, what type of treatments are available, what do things mean, and help you understand what's going on. In order to do that and to help people find these videos, I would really appreciate it if you would both like and subscribe to this YouTube channel so that it helps make this message more widely available. Just by clicking a button, or two buttons actually, you help promote these videos so that other people can more easily find them. If you are in need of a free support group, no cost, free support group for OCD, come to stopmyocd.com and sign up. We have a support group that you're welcome to attend, no matter where you are in the world. And if you're looking for exposure therapy, check out www.rxxrt.com for exposure therapists and some of the latest technology available to you. Thank you. Thank you for your interest in breaking the OCD stigma. Please help me make these videos more accessible by clicking the like and subscribe buttons below.